Welcome to Focus on Seniors, a television show sponsored by Helping Seniors of Brevard County, Florida. The show is designed to make you aware of senior issues, needs, and resources available to help us age in place and with dignity. This show will help you as you develop your own aging and care plan.
I'm Joe Steckler, and welcome to Focus on Seniors, the television arm of Helping Seniors of Brevard County, a show designed to provide you with information on how to develop your own aging and care plans. Our topic today is hospice care. With me in the studio is Dr. John Brodnan, who is the Associate Medical Director, and Michelle Fuller, Community Outreach Specialist for Wuesthoff Hospice Programs here in Brevard County. And I want you to pay particular attention, viewers, to today's show, because this is something more of us need to have an eye-opener to what can be done to help so many families that are just simply afraid to ask for hospice care. Is that a fair statement, Doctor?
I think that's a fair statement.
Michelle?
Very fair.
I hadn't even planned to say that. That was not on the prompter or anything at all. But it is a true statement. And I think I'd just like to set the stage, Dr. John, about the origins of hospice.
Well, hospice originated, I believe, in Great Britain in the 60s. And it started out as most hospices did, taking care of the cancer patients that were terminally ill. And that's kind of the way hospice started out for a number of years, probably in Brevard County as well. But now, hospice is now, it's a minority of patients that are in hospice now that are cancer patients, actually. Only about 40% of patients in hospice now are cancer patients. And
is that right?
That's right. And so, it's an expanding area. We have approximately 80% of us will die from some chronic illness, so we're going to need care, late in life. Dementia's become a big disease that requires hospice care at the end of life. Cardiac disease, lung disease, emphysema, liver disease, and kidney disease are big ones. So we're seeing an expansion, get an aging population. Lots of people need care at the end of life.
It's something I never thought about. It was in the only about the 80s that we started developing more of the, programs to take care of seniors, like a respite type programs. It wasn't something that was available all throughout the United States. And when we originally started these programs, they started off very, very minimal, just like, let's say, hospice. But the need for respite care for seniors has grown tremendously with an aging population. You're the first person that I've had on any of the shows about hospice that has mentioned the impact of the senior population on hospice care. Do you think that we have enough hospice houses?
Probably not. Probably not enough hospice houses, not enough hospital doctors, hospice doctors and nurses. It's just an expanding area that it's underutilized, I'm sure. Your work is strictly with hospice programs then? Well, right now I'm still a practicing pulmonologist, a lung physician, so I'm doing this.
You're doing both?
Both. Mm-hmm.
Okay. All right. Michelle, what else would you add to what Dr. Brodnan has said about the origins of hospice? Any additional comments?
Well, I think it's a relatively new movement in the United States. When you consider it was only in the late 70s that it started in the Northeast, and it's slowly creeping down, and awareness is slowly growing. But as our population ages at a remarkable rate, and there's a significant number of people who are now in a caregiver role for multiple generations. We have the sandwich generation, which is caring for grandparents, parents themselves, and their children. We really have to get the message out of exactly what hospice is.
And you mentioned a key word, caregiver. Mm-hmm. This is something that with an aging population across the United States, we tend to neglect the fact that the caregiver is a very important part of the caring equation. And hospice takes so much of the burden off of the caregiver, mm-hmm. a good hospice approach.
Absolutely.
One of the things that, what is the purpose of hospice? What does it do?
Well, the main purpose of hospice is to relieve suffering for patients of all types at the end of life. And that's really the sole charge that we have in hospice, is to provide that, not only for the patient themselves, but for their family and in turn that helps the patient. So, I mean, that's really, and there's multiple ways to do that. There's actual physical pain, which we can relieve. There's psychosocial, emotional pain that has to be addressed by social workers and by the chaplain and so forth. And then there is spiritual issues. Sometimes that's religious, sometimes it's not. And, those are all part of the pain and suffering that we're charged with relieving for hospice patients.
That's one of the things that I think that has evolved over the years, is that we realized the importance of what you all call the team approach. Mm-hmm. And Michelle, as a community outreach person, and you've been on our hospice shows before, explain what Dr. Brodnan was talking about. He mentioned so many different things, but that's part of your team. Who comprises your team at Wuesthoff in administering the hospice program?
It's good to know the team, and it really covers every facet, as Dr. Brodnan mentioned. So you have a medical director who really orchestrates the care of the patient. Now, some patients will want to maintain their original physician, their internal med, or whatever doctor was caring for them, but oftentimes the care of that patient is relinquished over to the medical director in orchestrating this care. The next person is going to be a registered nurse, who is going to be probably the most involved with the patient on anywhere from a daily to bi-weekly, whatever the need assessment turns out, the number of times the nurse needs to see the patient. There's also a home health aide, which is a critical part of caregiving and assisting with bathing and your activities of daily living. There's also your social worker, which is a wonderful addition to the team, not only for the patient but for the family as well, because it allows the family, it gives them one-on-one access to someone who knows every resource in Brevard County and can help guide them through, how do we keep mom at home? What other services are going to be necessary to keep mom at home if that's where mom needs to be? Or if mom's care is going to go beyond what we can do at home, the social worker can help them with that transition. The additional people on the team are the chaplain, which they help the person find whatever spiritual outlet they need. So regardless of your spiritual beliefs, the chaplain is going to facilitate that for you. And then the other critical component is our volunteers. We have over 300 volunteers as part of the hospice program that do everything from reading a book to the patient to transportation. Just a number of, we have pet therapy dogs.
The hospice program is like the hospital itself. It would be very, very difficult to exist without volunteers.
Absolutely.
They play a great role.
Mm-hmm.
Does Wuesthoff still have, you're the medical director though, Dr. Brodnan, mm-hmm. right?
Yes.
Okay. Then, do you still have the unit? I know you have a new hospice house, but do you still have the hospice unit in the hospital?
That's actually moved to a new facility.
It has moved to a new
facility in Rockledge. Beautiful facility.
Well, we're going to, as part of this show, while we're talking now, we'll eventually move to the hospice house and shoot a 2 or 3 minute film clip. And your director at the facility is sitting here in the studio watching what the two of you are saying, mm-hmm. so she's got a better idea what she should or should not say on the
yes.
camera. But, hospice itself. All three of us were laughing about care, what is happening. And when you approach the end of life, so many people neglect the fact that patients in hospice care can still be happy. And that happiness, I think, is engendered by the way the hospice team approaches what they're doing. Mm-hmm. As a doctor, what would your comment be, Dr. Brodnan?
Well, I think the interesting thing about being in a team, we doctors are used to sort of being in charge, but right. in a hospice team, it's completely different. I mean, I'm sort of the medical director, but in certain instances, I'm just a bystander watching or maybe facilitating other people do their jobs. And, there may be a patient that has a particular need from the social worker, and he sort of takes the lead and does most of that. And so it's interesting working still in the hospital a lot where the doctor's sort of in charge of things. This is different, and it's refreshing in a way to see other professionals work together, but so as sort of as co-leaders of the group. And I
would suspect, though, that it takes a special doctor to be able to do what you just described?
It's not easy.
It's not easy.
Yeah. And it's a learning curve. Yes.
I think it says a lot for you for wanting to do it.
Mm-hmm.
But I think it's a good point to talk about hospice care. There's been so many things said. There's another word we attach to it, palliative care. And there's also a thing about aggressive care. If you're in a hospital, the approach is more aggressive to try to keep the person alive or bring them back where they can have a quality life. And with the hospice care, it's more like they can have a quality death.
Yes, and that transition is often difficult, especially for families, I think, because many of the patients that we get into hospice are in the hospital. We're trying to do everything we can possibly do for them, and then we reach a point, they reach a point, they sort of come to grips with the fact that there's not much more we can do. And so the attitude and the thoughts shift to palliation, which is to try and make you comfortable, do whatever we can to make your remaining days comfortable, dignified, either at home. Most people want to go home. Most people want to live their last days at home if they can.
Yes.
And we try to. In the end, our job as hospice people is to provide information for the patients and then ultimately aid them in making their decisions, because they do need some medical input, but ultimately they want to and need to make their own decisions, and we certainly support that. And if they want to stay at home, we try to do that.
It would, my opinion now, I think would be, well, I don't know. After I had my hip surgery, I did my rehab at home. Mm-hmm. And of course I had a pretty good team that came out and did the rehab for me, but so many other people have to go to facilities for rehab. Mm-hmm. But we're not rehabbing a person in hospice care. We're trying to make them comfortable. And that's something that a lot of people, we don't, this is a show on information to help people watching the two of you describe hospice. I want them to learn from what you do at the Wuesthoff Hospice House. When we talk about making patients comfortable, you've talked about the team approach, but there's also a medical aspect, and that involves the use of medications. And how do you arrive at something like that? Do you work with the families? How do you do that, Doctor?
We work with the families. We work with the patients. In the end, the medical part of it mostly is palliative care, giving medications for pain, mostly pain, or shortness of breath, or things that happen at the end of life. Those are the main things. And so, we have a certain criteria that we use to control their pain with medications, either oral medications or intravenous medications or whatever. And those are typically the patients that wind up at the hospice house because they need more care than they can possibly get at home. They may need intravenous medication, which needs to be delivered by a registered nurse, which is difficult to do in the home setting. It can be done, and we do it sometimes. But those are the patients that wind up at the hospice houses for specific things and needs that they have at the hospice house.
Okay. Michelle, you have anything what Dr. is saying there?
I think the statistic, it's important to know that 8 out of 10 Americans would prefer to be at home. And, hospice, one of the myths is that hospice is a place. Well, think of it more that hospice is a philosophy. And I love the hospice house because it is a window for the world to see. It's a tangible place for them to begin to think about and understand what hospice is. But a majority of the hospice care is given in a person's home, and we can't define that, or we define that very loosely. Your home is perhaps a trailer, or perhaps an assisted living facility, or perhaps a nursing home.
Yeah, that's a point to make, that hospice does go to assisted living facilities, and hospice does go to nursing homes.
Absolutely. A lot of our patients live there.
Mm-hmm. Do you ever find any resistance at a nursing home to a hospice program coming in?
There's a little bit of occasionally, because there's always who's in charge, who's in charge. And we as hospice try to tread lightly on that subject. We're there to serve the patients, as are the nursing home, and we try to take care of the medical hospice part of things, pain management, other things that they may need. And of course, the nursing home is there to provide their daily needs. Yeah. And there are other medical problems that these patients have that are not necessarily related to their problem. For instance, if they have lung cancer and they're in hospice for their lung cancer, they may also have diabetes. And sort of the nursing home facility has to kind of take care of that. We take care of the cancer and their pain and different things.
It's, I think in this case, this is another area I think that probably the public needs to be better educated on.
Yes.
I think people need to know more about the services that are available and get over the fear factor.
Mm-hmm.
You know, it's inevitable. We will die one day. I mean, you don't get around it. I happen to believe that there's a better life after this one. That's my belief. But I'd like to be here as long as I can.
Sure.
And I think we all like that way because I enjoy doing what I do to try to help people and work with people. And I think that's an approach that a really good hospice program does that. And I want to say this, I want viewers to know this, that it was, I think, 3 or 4 years ago that you had a worker, Charlie Antoni, that won the Healthy Heart Award for the entire United States as an outstanding hospice worker. Mm-hmm. One guy for 50 states, and it was old Charlie. Mm-hmm. And I can remember many times Charlie said at the end of the table for this hospice show, and every worker, every program I've had with hospice for 12 years has been the Wuesthoff Hospice Program. It always has. And I don't know how I've always centered on that, but I have. But you've always been willing to come and share it with others. Can you talk for a minute, Doctor, about if a person enters hospice care and his doctor is still working, his or her doctor is still working with them, you as the medical director, do you find patients that go beyond the generally accepted the prognosis is 6 months for hospice care? Is that correct?
Yes.
Okay. Do you have patients that go beyond 6 months?
Yes, numerous patients do. Actually, Medicare has a criteria, and we have to sign a form that says if a patient of this type, 51% of them will expire in 6 months. But there's numerous patients that go months and sometimes even years beyond that, especially in some of the diagnoses that are difficult to pin down exactly. Dementia, patients decline slowly.
That would be a hard area.
It's a very difficult one to try to say that they belong in hospice and they should stay in hospice, but they have tremendous needs, especially the caregivers. So and cardiac and lung disease, the patients can get better and get worse and get better and get worse, but the general situation is they decline over time. So those are some tough ones.
But a thought I have is that if a person is very sick, that if they're receiving hospice care and they have the ability through the use of correct medications to take some of the stress off of their body and their mind, that it sometimes might help with the healing process. And I see you shaking your head. Mm-hmm. Have you seen this, Michelle?
We've had graduations. We've had folks that oftentimes when hospice care comes in, the person is finally getting the pain management and the medical management and attention that they needed, and sometimes they'll get better. I always tell people, it's not a bad thing to graduate or get kicked out of hospice because you've improved. And, it's not every time, but it has happened.
Okay. Who recommends hospice care, Doctor?
Generally, it's the doctors, but a lot of times it's the families inquiring. Oftentimes it'll be started by a nurse in the ICU or in the hospital or somewhere, or a family member asking. In the end, 2 doctors have to sign off on it, but oftentimes it's initiated by the patient sometimes, the family, doctors, nurses.
But I think it's my understanding that in order to have hospice care paid for, that the doctor has to sign the order.
Doctor has to sign the order. 2 doctors at the beginning have to certify that they believe that this person has a 6-month life expectancy, so to speak. And that starts the process, and the patient basically signs over to the hospice Medicare benefit if they're a Medicare patient, which most of them are, and that starts this process going.
So if you qualify for Medicare, hospice is paid for.
If you qualify for Medicare, you are entitled. You have already worked and paid into Medicare, and you're entitled to the Medicare hospice benefit. So
hospice covers the medicines, the drugs, it covers everything.
Virtually everything for whatever their hospice diagnosis is, yes.
Okay. What happens if a person is not covered by Medicare? How do those people get paid?
Well, about 90% of the people in hospice roughly are Medicare, Medicaid.
Okay.
The remaining most have private insurances, various ones. Most of those private insurances have a Medicare, have a hospice benefit. Each are a little different, but those people are covered similarly.
Okay.
And if they don't have any of those options, we still accept them into the program. No one has ever denied hospice care.
I was waiting for you to say that.
Yes.
I didn't want to say it, but I wanted you to say it, because that's another thing about, I think in all hospices are this way.
Sure.
We have Hospice of St. Francis in the north. We have the Holmes Health First has their hospice program. You have your hospice program. And there's, what is it, Vita Hospice.
Mm-hmm.
And that's a for-profit.
Correct.
What's the difference between for-profit and non-profit? I mean, is there any difference? I don't understand.
It really comes down to, and I've had the benefit of working for a for-profit and a not-for-profit, really what it comes down to is at the end of the year, a not-for-profit has to make that balance sheet come down to zero. So how they've gotten to that number is, it's either through increased services or spending as far as staff.
It still does the same thing.
It all does the same thing.
Okay.
There's no, it doesn't make a hospice better because it's a not-for-profit. In fact, a for-profit hospice, they're contributing to the Brevard County tax base, quite frankly. But it's all good.
Do you find any difficulty in having enough registered nurses and workers in, the team workers? Do you have problems, or do you think? I guess what I'm asking is, there was a shortage of nurses for many years. Has that sort of rescinded enough to where our hospice teams can count on being manned?
I think the hospice is exploding so much
that
that we're always right on the edge, and I think part of that is it takes a special person to be a hospice, whatever, nurse, doctor, etc. So the pool of nurses out there, while there may be this big pool of nurses, there's probably a small pool of nurses that really sort of their calling to do hospice, and so we're always looking for those kind of folks to help us.
I know what you mean, because when I told this story on one of our television shows, that when I was the director of the Brevard Alzheimer's Foundation, for all the people who worked in our daycares, I actually had a part in interviewing the people, and the question I always asked was whether or not they could hug a dementia person. Mm-hmm. And if they couldn't do it, I wouldn't hire them. I would just, because I felt that if senior people came into our daycares, that they needed to be treated with the same type of love they get at home, or in many cases more love than they had at home. And
Absolutely.
That's probably something that you find in hospice too, that the people can be better cared for in their remaining days in a hospice house.
Yeah, we hope so.
Yeah. The one thing that I know, since your hospice house director is sitting here listening to us do the show, I want to make sure that when we go on to do the camera site work, that she points out where the families can throw sleeping bags if there are not enough beds in a hospice house, because it's my understanding that if they have a lot of grandchildren, you just let them come in and take that hospice house and treat it like it's their home.
Absolutely.
That's what it is.
Yeah, I mean, they really want to be at home, and this is the next best thing for them when they can't be at home, is to be. And you will see with the cameras when you go there. But the rooms are large. There's beds for other people aside from the patient. There's a sort of little porch that looks out into a wooded area. It's beautiful, and it's very serene, and it's, like you said, there's lots of room for everybody, and there's not visiting hours, so to speak. And
there's no visiting hours.
No. They've even gone so far as to put in a family shower and showering facilities, because if you've sat with someone for a long time, there's nothing better than going and just being able to
You have that?
take a shower. Yes, there's
Okay.
a family.
Did you think of that when you built the place or not? Did you have to do it afterwards?
I think that so much thought went into the building of this place. And again, we talked about people being called to do this. I don't think people get into hospice to be rich. You truly have to have a calling to do it. Everybody who was involved in the building of the hospice house has most likely cared for somebody and has been in the very same shoes that our families have been in, are in.
What do you think we have not covered, Dr. Brodnan?
Well, I think what we haven't perhaps covered enough is that hospice can provide care to people long before people think they can.
Okay.
There's just this large pool of people out there that, for whatever reason, their diagnosis, their family situation, their caregiver situation, there's lots that we can do for patients. And just to talk about the caregivers, there's different types of care in hospice, but there's one particular type of care called respite care. If you're in hospice,
yes,
you're at home, all types of diagnosis, but frequently in some of these chronic diseases where the caregiver is with that patient 24 hours a day, days, weeks on end, we have what's called respite care, and it's purely for the caregivers. The patient can come to the hospice house, they can stay at the hospice house for 5 days, the family can get whatever relief and time and rest that they need, or if they need to go to an emergency somewhere else or to a family reunion or something to kind of recharge their batteries. That's all part of hospice, paid for as part of the hospice plan. They come in, taken care of, then they go back home.
Hospice will do that?
Yes.
See, that's something else we learn.
Mm-hmm.
You always learn, because I can remember years ago, you couldn't hardly find a nursing home that would take a patient for a weekend in order to give a family a break. It just didn't do it. But I have to tell you, here in Brevard County, they did it. Mm-hmm. And I can remember one time I had a family that needed help so bad. I called a manager of one of the nursing homes, and he had a bed set up in his office so people could sleep there.
Mm-hmm.
They really did. And they took care of them.
It's critical that the caregivers get the care they need. Otherwise, they're not equipped to care for their loved one.
What else would you add, Michelle? You're the community outreach person. What has not Dr. Brodnan covered?
I just think that people need to reposition their thought of hospice in their mind. Get away from the thought of it being the last 72 hours and look at the quality of life, for much more than that. Bring in hospice sooner rather than later. Allow us to help you through this journey. Let us share the journey with you, and let us make it an experience that you look back on and you're pleased. You're pleased with how your loved one was given dignity and comfort and love at the most critical time in their lives.
I think that's an important thought that maybe we could have talked a little bit more about the fact that the sooner you do it, the better off you are.
Absolutely.
But we're out of time, and I want to thank you, viewers, for watching today's episode of Focus on Seniors. If you have questions or comments, please call radio station WMEL 1300 at 321-631-1300. For more information on senior care and resources, visit our website, helpingseniorsofbrevard.com. And I want to thank Dr. Brodnan and Michelle Fuller for being here today for an excellent presentation on hospice. And I hope you will avail yourself of more information about hospice care from all of our hospice programs here at Brevard County. They're a wonderful program. Thank you for watching.